my name's Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns in far north Queensland, and tonight we're having another one of our monthly talks. And it is my great pleasure to invite Dr. David Shepherd, who is another orthopaedic surgeon based in Cairns, and he's going to talk about ankle injuries, and then we might just get him to talk about some other stuff as well, if we can. Yeah, it'll be a surprise.
All right, thanks for joining us. This talk's about ankle injuries.
I'm going to sit here, sorry.
So, ankles are commonly injured. This is a common injury, and so people hurt their ankle, they come in, and there's like a spectrum of what's going on. So, at the sort of low-grade end, it's the ankle sprain. Okay, oh, there we go, hurt it, got pain and swelling maybe, and it all gets better and goes away, that's fine. And at the other end, we've got fractures. Okay, so from a practical point of view, somebody hurts their ankle, they go in, they'll have an x-ray usually first up, and if they find a fracture, then off they go to the fracture clinic and they go down that fracture clinic pathway, and I'm not really going to talk about them. The other group, there's no fracture. Now, they may have an ultrasound or maybe an MRI. They may have an injury to the lateral ligament complex. And so they're down at the sprained end, and that's more what I'm going to talk about. So I'm going to present this case. So it's a 26-year-old woman. She's a Defence Force member. 3 months before coming to see me, she had a fall down the gangplank. She was unable to wait there for 3 days. So you had to get, kind of picked up. Some people hurt their ankle, go down, get back up again and go, what was that? Nah, she had to be picked up. Couldn't take weight on it for 3 days. She had some physio. It was a little bit better, but really not much good. So she's getting pain around the lateral side, felt unstable. Did an anterior draw, so grab a foot, drag your ankle forwards, and also I felt that if I stressed a syndesmosis, so basically shifting laterally, it gave her pain. Here we go, she had an x-ray, there it is, perfectly normal. She had an MRI scan, and here it is, and radiologist, so the syndesmosis, high ankle ligaments is code for the syndesmosis. There we go, it's normal. In fact, I went back and looked at this lady's films, MRI films, and I compared them to normals on the internet, and I couldn't find anything wrong with these films. Okay, so I think her MRI is genuinely normal. So then we arthroscoped her ankle. So for those of you who don't see into ankles very much, hopefully the pointer, here we go, we've got the mouse and the pointer go. So this is the fibula, this is the tibia, this is the talus. So this is the ankle joint. And this is the area we're looking at with the arthroscope. So this is the tibia, this is the fibula, this is the talus, okay? Now, what I want you to do, the next slide, it's got the same picture on the left-hand side. And on the right-hand side is the arthroscopic picture when I stressed the syndesmosis. So I want you to look for the tibia up here. Gone. Gone. So this lady's ankle was quite unstable. The device we used to internally fix this, the rep was in the theatre and she gasped. She said, oh, this is the most graphic I've seen. But you can see here, there's just space. So this lady's ankle opened up 2 or 3 millimetres. But MRI is normal. Plain X-ray is normal. I think the ultrasound showed a lateral ligament injury. So there's a thing called the Low-Hansen classification of ankle fractures, which basically was on the way out when I was a trainee because it was too complicated to use. Now these Weber classification. What these guys did was they got some cadaver ankles and they broke them. And they recorded what went first. So anterior inferior tibiofibular ligament is also code for syndesmosis. So this is a supination external rotation injury, like that, okay? So bit hard to see on the thing, but that is very common. That's probably the commonest ankle injury. Supination adduction, again, they go the other way. The talus goes medially, so you don't get it. Pronation external rotation, yeah, they get it too. So for the common ankle injuries, almost the first thing to go is your syndesmosis, or at least part of the syndesmosis. So what's the clue? Well, I think this injury has been poorly recognised for a long time. But in recent times, I've sort of recognised a few. The common things, they're young adults, they're 20s and 30s, and they've had a moderate energy level with their injury. They're not just walking along straight and level and put their foot down wrong and roll their ankle a bit. That's not enough injury. It's not like they've fallen 1.5 meters, though I did see one or two that could have done it like that. It's like this girl was on a gangplank. I think it was fairly steep. I had another guy who stepped off a forklift. So they've just gone down one step, you know. They've gone down one step and missed their footing. And of course, they don't get better. And they don't get better because their ankle's unstable. So as they're going around doing things, the fibula and tibia are separating. And that's giving them pain, and they're just going, this is no good. And there's not much on MRI. So if you're relying on MRI to pick these up, it's not going to work. Like I said, the guy who stepped off the forklift, I went back and looked at his MRI images as well. They were deadpan normal. I pulled up his film and this lady and compared them to normals on the internet, and I couldn't find anything wrong with them. So I think their MRI is genuinely normal. But the reason is that their fibula rebounds. So if there's no stress on the ankle, it just sits where it should be, and you can't see a gap. So like a fracture on X-ray, what you're looking for is 2 bits of bone with a gap in the middle. So you need the gap in the middle to pick that it's broken. But this one, the fibula just flips back to where it should be, and you know, you can't see it. I think if they have an ankle fracture and they get put in a cast and get immobilised for 6 weeks or so, then I think there's a fair chance they'll join up. So that's the non-operative treatment of ankle fractures, and it does work. But most of these guys, they won't go into a cast or a boot. They'll be walking around on it, and because they're walking around on it, it keeps opening it up and it doesn't give up. But if you internally fix it, and we've got some good gadgets for that, then you stabilise it, it heals up, and they do very well. We get comfortable functional ankles. So, like I said, the other guy, the guy who stepped off the forklift, he did heavy physical work on his feet. He turned up to see me at about 6 months post-injury. I can't remember what he was doing at work, but it was not much. And you know, it's that classic, oh yeah, his work cover, he's just having a whinge. Fixed his ankle. He wasn't as unstable as this. Fixed his ankle. Comfortable, stable ankle, he's back at work. Again, doing his heavy physical work for his full hours. He was a bloke who was 30. So it's like, yeah, you know, if any patient is gonna, you know, fail their rehab, it's going to be work cover patients. So I think it really works. It really is out there, and it really is easy to miss. And they do very well if you internally fix them.
There's the index of suspicion clinically that they don't get back to full weight bearing and like getting back to running at 3 weeks after a plain old ankle sprain, or not able to get back to work where they're spending a lot of time on their feet.
Yeah, it's like they just can't function.
In weight bearing.
They can't function. So when they...
How soon do you call it? So do you call it at 6 weeks, or do you call it at 3 months, or have you seen it before?
It'd be a tough call at 6 weeks. By 3 months, so if you had a lateral ligament injury and nothing else in your ankle, you know, by 6 weeks you should be pretty good. You know, you'll be walking around on level and you're back doing most of your activities. And by 3 months, you're a bit deconditioned, but you can do it, but you may be a little bit sore at the end of the day. Whereas these guys, at 3 months, 6 months, they're just still crawling around. They can't, you know, and they just kind of come in and say, they can't express it in words, but they just can't function. And it's like, oh, it just hurts, it feels wobbly, it's going to give out on me. You know, as soon as I do anything on it, it just feels bad. You know, it's like an ACL injury in the knee. You know, when they get pivot shift, that drops them to the ground. They can describe that for you. But this is just very sort of protean, just that their ankle is just bad. But they can't, you know, they feel a bit unstable, which gets confused with lateral ligament injuries. And often they have a lateral ligament injury as well. But yeah, it's kind of like that. That's when they're turning up to see me, is that 3 to 6 months down the track. They've gone down the non-operative, you know, they've been sort of, had some investigations which are, nothing to see here. But they never got better. And they're still miserable. And that's when I kind of look back at this sort of stuff and you start to sort of pick up the pattern. And again, clinically, I don't think you could really pick them clinically. And I think I accept that I'm going to scope a normal ankle at some stage. But, you know, you get in, you put the arthroscope in, and I picked that one because it was so graphic. But some of them, you just jiggle it and you can just see them jiggle a bit. Like the 30-year-old guy at forklift, he just jiggled a bit. It wasn't like this lady who separated 3 mil. It just jiggled a bit. So, yeah, I think really the gold standard is having a look at the arthroscope. But the index of suspicion builds because of, you know, these sort of things. You know, they've had enough energy in their injury. They're young adults, or I think another one you could add to the list is overweight, particularly women. So that, yeah, and it's
The MRI scan, do you want to pull that up and just show us what it doesn't show? Does that make sense?
Well, okay. This is the anterior syndesmosis here. I thought, you see there's fluid in between the tibia and the fibula here? And at one stage I was thinking, it's a sign. But in fact that's there on the normals. There on the normals. I went, okay, it's not a sign. If you're in the textbooks, there's quite a thin layer, a slice or two lower than this. There's a thin layer of black, which is fibrous tissue that runs across here. I think this is a bit further up. And then there's not much at the back.
But there's show the AITFL and the PITFL have separated, which would give you that indicator.
It kind of peels, you know, it sort of lifts, and you know, from the bone. It just sort of hovers there, and you're sort of thinking, is it a bit of extra fluid? Is it? It doesn't kind of. It's not like a rotator cuff tear where it comes off and it sits miles.
See, the things that show up well on MRIs, things like cuff tears, where you get tendon, fluid, bone, and you go, oh look, there's a big gap in the middle. You know, same with ACL. You know, you've got ACL, you've got space, you've got bone, and you go, oh look, it's ruptured. Whereas I think with this, there's enough strength in the fibula and the interosseous ligament that it just sits in the right place until you put stress on it. And again, stressing them clinically, it doesn't take much to get you sore, you know. And I don't think that's a great discriminator, but.
And the X-ray, I thought it had a little corner off there on the X-ray that you were pointing to. No, I think it was the second lot of pictures.
That was the same as the first picture.
Oh, sorry, I thought you were trying to show.
I just copied the image.
Oh, that's all right. And put a
I just put a circle on it. It's the same image. But if you like, what I'm trying to show, here's what we see with the arthroscope, which most people won't get the opportunity to see. And here's what we see with the X-ray, which I'm thinking most people have seen. So, yeah, you know,
you think there's a difference in the gap there, in the, around the talar dome? Do you think there's a? Do you think that?
Hey?
Is widening.
Well,
Yeah.
yeah, does that count
It's-
as widening is kind of the question.
But-
Do you know what I mean? Like,
but-
is it enough that you... Because
The
obviously
gap
the
here
X-ray is reported as
Doesn't
the
well.
same
that
as the
depend on
gap
the
there.
obliquity of the angle?
Well, correct,
I-
yeah.
With my map work, so with work cover, I do this work for work cover where I'm often reviewing MRI scans of ankles like this. And, you know, you kind of look at them and go, okay, not much. I've seen one where there was actually a little sliver of fluid down here, and you could see that this part of the joint space had opened up a fraction. And I went, nah, that syndesmosis is going to be busted.
Right.
Because they actually had just a fraction of lateral shift. And that was on that medial side, you could see that there was like a millimetre of fluid that there wasn't on the lateral side. I don't think you picked that on a plain X-ray, but, and I went, nah, that'll be one for sure.
How uncomfortable is it for the patient to put their ankle under stress? So could you not image them with their ankle in a certain position to see if it's actually a
Yeah, I suppose you could.
That's why I'm wondering why the radiologist would a stress X-ray technique. that they
It's-
do.
Maybe it will happen over time. And I think this sort of injury has been under-recognised for a long time. You know, I think back, 20 years ago, we would say, oh, yeah, I'll see you later, and throw them out. Yeah, you're all right. Nothing to see here. Yeah, it's ankle sprain, you'll get better. And now, you have a look at the scope, and you start to see ankles like this, and you go, oh, we must have missed it here. I think as time goes by, eventually the radiologists will kind of cotton on to this, and that they'll go, oh, hang on, here's real pathology that we're not demonstrating, and then they'll go looking for a way to do it. The only thing is with stress injuries when people are awake is that they can just spasm and you can't demonstrate it. It's like demonstrating a pivot shift in an ACL. With the patient awake, I reckon people who genuinely ruptured their ACL, my chances of demonstrating a pivot shift would be 25-30%. Because as soon as you try and shift them, their muscles contract and pull them back.
Once they've had it done once, they never had it.
And they never let you do it again.
Yeah, that's right. In this one, I'm not sure exactly how they would do that, but stress stuff on awake patients is prone to missing them. Whereas when you're doing this, they're anaesthetised, so you do whatever you want. They don't tense their muscles. It's like the whole point. That's the definition of an anaesthetic, really.
And do you want to talk about the technology of the reconstruction and the repair, the principle between, do you want to talk about the difference between we used to put a screw across, which we do now? What? You don't want to hear about that?
No. Because the old-fashioned method with the screw is fraught with problems.
Yes, how we used to put a screw across a
Yeah.
diastasis and then take it back out again, but now we
Yeah.
don't. We use this magic Arthrex device.
I mean,
But Peter can tell us all about it.
we used that because that's what we had. We didn't have anything else. But there was a degree of skill in putting it in. And, the golden rule was you do not lag the screw. So you hold it reduced, you drill it, you tap it, because in those days we didn't have self-tapping screws. You drill it, you tap it, you put the screw in. So it's holding it, but it's not compressing it. If you compress them, you over-compressed it, and that squished the ankle and they did badly. I suspect they will get stiff.
Now they get dorsiflexion back.
They won't get dorsiflexion back. Yeah, there you go. I did see one guy with a tightrope, the Arthrex tightrope, that was stiff, and I couldn't help but thinking maybe he was over time.
I've seen one as well that's stuck
Yeah.
in plantar flexion.
Yeah.
I know the way there.
I think the difference with a tightrope device is you don't have as much mechanical advantage. You've got to pull on those strings, and if you pull on those strings as hard as you can, then you're probably not going to over tighten. So it'll tighten in and then stop. Whereas if you've got a lag screw, you can really crank them up because you've got a huge bite in the tibia, and you can just keep cranking it up, and over time. So you don't want to over time.
It's supposed to move for a reason.
Well, it's a joint. It moves. That's right. It's got to move. For it to function, it's got to move. And that's why I had to pull the screws out, because either the screw would break or it would come loose. And it was easy to just take it out. But you had to leave them in 6 weeks for all the soft tissues to heal up. But usually you'd see them at 6 weeks and go, oh yeah, we need to take your screw out, and you do it a few weeks later.
So this, like the Taylor Dome and the kissing injury on the medial aspect of the ankle, when you do a lateral ankle sprain, the kissing injury on the medial aspect with a talus,
You mean the articular cartilage?
yeah,
Yeah.
Taylor Dome lesions and
Yeah.
stuff like that, that too is getting more easily recognised clinically. Because you can pick up these ankles straight away that they're not going to do good, they're not going to recover
not
quickly.
responding.
They're not going to recover
No.
quickly because it's more than just a lateral ankle sprain.
Yes. Yeah. So if you do your lateral ligaments, so ATFL and nothing else, then generally speaking, you'll do well with non-operative treatment. I think your ankle is slightly more lax than it used to be, but if it's only one injury, it's probably not enough to be a problem. You know, guys like typically Army, who spend their whole time running around in the bush at night, putting their foot in holes and spraining them, you know, by the time you've done this 20 or 30 times, the poor old ATFL's knackered, you know. But the problem is that, okay, they get ankle sprain is just this kind of heterogeneous basket of people. So that you get x-ray, and if it's not broken, oh, this is an ankle sprain. And then there's guys who have just got an ATFL injury and nothing else, and they'll just get better. But then you've got guys who've got, well, an ATFL injury and syndesmosis injury, Taylor Dome fracture. They'd be the leading candidates. And they don't do well. And even Taylor Dome injuries, articular cartilage injuries, are hard to see on MRI because it hasn't got the resolution. The articular cartilage in the ankle is really thin compared to the knee. 3 mil, maybe more. You can see that on the MRI. Ankle, yeah, maybe only a mil and a bit. I don't know, I haven't drilled any holes in any, but you know, it's only quite thin. So the MRI, the little pixels, you're only getting just a couple of pixels. So to try and pick a bit that's missing is pretty hard.
Do you think clinical assessment is the way to pick that up? Because that tenderness on the medial Taylor Dome, when you draw the ankle into plantar flexion and then the ankle into dorsiflexion, that tenderness on the medial Taylor, I think, is palpable.
If it's not too far posterior.
Yeah, I think you're probably right. I guess it sort of comes down to, I guess in a lot of ways, the clinical examination is kind of helpful, but in the end, is kind of stuck with this patient whose ankle is non-functional and they want you to fix it. If you go and you find something, you beauty, oh look, there it is, there's the trouble, let's go fix it. Whereas you don't always find something. And that's where, you know, the ones where you find something, yeah, sure. Oh, they got a chunk out of their talus on the MRI. Oh, okay, we better go and just, you know, clean it up. You know, if they do have, sometimes you do see a syndesmosis injury on the MRI. Oh, okay, we better fix that. But there's quite a lot who they don't, and that's why I'm sort of looking at those sort of clinical factors. They're sort of risk factors. The couldn't walk for 3 days is a key risk factor. So if you fall down, hurt your ankle, and can't get back up again, you've broken something. So, you know, that's like I've done enough bike riding to see guys. So I have this rule for bike crashes, okay? So here we are, a big bunch of cyclists riding along. Some guy goes on the ground. And if that person is back on their feet before I get to them, then they're all right. They get back on their bike, they ride away. If that person is not back on their feet by the time that I get them, I get to them, then there's going to be trouble here. And mostly they don't ride away, but usually they haven't really done anything terrible. If they can't get off the ground and the ambulance has to come and pick them up, they've broken something. And it's been a pretty reasonable, it's been pretty accurate, you know, and that's where this ankle sort of, so she went on the ground and she couldn't get up, which that says she's broken something. So more or less, the ambulance had to come and pick her up. she couldn't walk away. So that kind of goes, she's broken something.
So the risk we have, it's a bit like an appendicitis. If you're doing enough appendectomies, you will have a normal appendix, a patient with a normal appendix. So there's a statistical probability that you will have so there is a statistical probability that as the surgeon, you will risk operating on someone who doesn't have a problem. So as you mentioned before, the clinical and the MRI assessment is not poor, but is not predictable enough for us to deny an operation to someone who is unable to weight bear.
And I think this is something which is, how do you put it? It's a bit cutting edge, in that until fairly recently, these injuries just weren't recognised. Patients were sent away, and they just put up with it. I suspect a lot of them got osteoarthritic ankles. So now, you kind of find a couple, and you go, geez, how many have I missed? And that's right, like Sarah said, it's like if every ankle you operate on is busted, then you've missed a few. So it's the difference between getting all the pathology. If you get all the pathology, you'll arthroscope a few ankles that didn't need it. So, and that's a risk, And you see guys who just fail rehab, and the classic patient is work cover, where they just refuse to get better. And usually, again, when you arthroscope them, you kind of have a look around and go, oh, nothing to see here. And then usually you sort of pick it, you go, oh yeah, okay, I know what's going on here. And you just go, well, okay. We could have got away without arthroscoping that guy's ankle, but you don't know that until you've done it, kind of thing. And it's not a terribly kind of morbid procedure. You don't knock people's socks off by having a look at the arthroscope in their ankle.
Do you want to start part 2 of your presentation?
Part 2?
Unscripted part?
Yeah.
I warned you
All
that you had a question. We wanted to talk about total knee replacement.
My question was sort of, I worked alongside the total knee and the total hip guys in marketing for many years, and I used to hear all this stuff, and I was thinking, because I worked in total shoulders and sports med, so I didn't pay too much attention. So there was a whole lot of stuff in the total knee world, like cruciate retaining cruciate, blah blah blah, rotating platform versus fixed platform and the medial pivot joint, and I thought, there's a lot of BS words going on there, and I thought, biomechanically, I've got no idea what the hell that means. I mean, does a total knee benefit from having its cruciate retained, both anterior and posterior, or what does this mean in total knee world? And most importantly, what does it mean for us when we're rehabbing these knees? Are they any different from any other bog standard total knee that we're rehabbing?
Okay. There is no knee prosthesis which preserves the ACL, or at least nothing which is done in any numbers in this country. It's possible that there's one out there, but pretty much everything trashes the ACL. And so then we come to the PCL. So, okay, so you've got to bung this prosthesis in, and then you need this knee to function. So one way or another, you need to have PCL stability, if you like. You need, for want of a better word, PCL function, okay? And then there's a number of ways of achieving that. One way to do it is that when you get in there and you, if you like, you trash the normal mechanism, so you take out the PCL. Oh, hang on, we still need PCL function, so that gets put into the prosthesis. So again, classically, there's a post on the tibial component, which meshes in a box on the femoral component. So that then provides that PCL stability. So in other words, when they're like going down steps, if you don't have a PCL, femur goes down here, it doesn't work. So you need something to take that load. So you can trash the PCL and then put in a prosthesis which copes with that. Or you can not trash the PCL and put in a prosthesis that doesn't replace it. Okay, so that is the PCL preserving prosthesis. And the only trick is that it's actually pretty damn easy to trash the PCL when you're doing
Just
a total
a
knee.
cut.
Yeah, if you just cut the top of the tibia off, oh, shit's gone. So, I did a course recently and did the tibial cut, and the guy running the course came over and had a look at what I was doing and went, "Oh, you've trashed the PCL." I was offended. It's not even leaving the PCL. I went, "No, look, see, all right, trashed. Well, how did I trash the PCL? We just cut it with this tool." And then I realised that, I probably trashed every PCL in my career. The only thing was I'd always used the PCL stabilising prosthesis. So it worked. So then, if you like, I moved on to a PCL sparing prosthesis. So now, when I cut the top of the tibia, I don't cut all the way to the back. I stop the cut, and then I use a little baby saw and go around a bit of bone where the PCL inserts and take all that. It's a bit of a faff around, but
Like a jig.
so
Like a jigsaw going around.
Oh,
no, it's a surgical saw. But
Oh.
there's a big one which got a blade this long and this wide, which you cut the top of the tibia off. There's a little one, so this wide and this long. They get the little blade cut vertically, so down on the tibia. So the medial lamps, yeah, that's what it's called, the middle of the tibia, the lump of bone the cruciates are on. Yeah, cut around it like that. So basically, tibial eminence, yeah. So you cut around in between the ACL and the PCL, like this. And then when I make the tibial cut, I put a mark on the saw blade with a pen, so that you know that when I get to there, I'm getting pretty close. And then I cut the tibial fragment into two, and then I take the two bits out, and that's left me with an island of bone at the back. But usually I leave that too big, and I've then got to come in and cut it down. And then if I cut it down, and I can just go back and just leave the posterior cortex there. Because if I leave a chunk of bone, then there's a little cutout in the back of the prosthesis to talk to it. But where you want to put the prosthesis is not always where that cutout is determining to go. So that's why now I have to then go in and basically take that sort of cancellous bone out until I've got just that posterior cortex, which is what the PCL's stuck on. Then I can put my tibial component where I need to.
And so why did you change to do PCL sparing? What's the benefit?
I think they do better. So, if you like, I changed companies. So I was with DePuy, and I went to Zimmer. So I said, well, what's everyone around town using? Oh, they're using Persona. And it was a PCL preserving prosthesis. Like I said, I went to the course. That was the course that said, oh, this is how you do it. And like I said, in the course, I trashed this guy with this cadaver, PCL. And I went, oh, hang on. How do I, oh, hang on. So I changed what I saw. I went, oh, okay. So then I changed the way I cut the tibia to make sure I preserved the PCL. Now, pretty much I've preserved them all since then. Now, I did have one that was tight flexion. I cut it.
Tight in, flexion.
Yeah. So if you cut the
Because the
PCL,
bone
Yeah,
block
no, yeah.
flop back in flexion.
Bone block might actually block you getting into full flexion, wouldn't it?
No.
No.
No, because it's recessed
part of the
below the
normal
level
tibia.
of the, it's not recessed, it's the implant.
There's a cutout for
There's
it.
a
Yes,
cutout in
yes,
the back.
yes.
Yeah.
That make,
Yeah. Now, okay. So, but there's more. Because it's so damn easy to knock off the PCL, the prosthesis companies want to have a bet both ways. So the Persona, and I've forgotten the name of the tibial, there's lots of different tibial implant. So you put the tibial base plate, the steel bit on, and then you've got the tibial plastic. And there's several different tibial plastics you can get. One of them is absolutely critical, won't function without a PCL that's intact. Oh, but they don't have that very much. They've got another one which is a bit more deeply dished on the medial side, and actually that functions all right if you trace the PCL. So it's like a bet both ways.
Just in case.
It's just in cases, yeah. So it's like
but they don't have the post. They don't have
Correct.
the post option.
correct.
All they have is the deeper dish on the medial
Slight
side.
deep dish. And that was where, like the LCX, it was a PCL sacrificing prosthesis, but it had a deep dish tibia, and that's what did the PCL stabilisation. Whereas the ones with the post have got a fairly flat tibial plastic. So you put a curvy thing on a flat thing, it'll sort of fall off. Whereas the problem with LCS was they didn't flex very well. So they didn't bend. Whereas if you went to the sort of flat with a post, which I did, they flexed a lot better. In fact, I just changed it. It's a long time ago. And the physio in the ward, Jason Hoffman was, he came up to me one day and said, "You're doing something different with your knee replacements."
Physios know.
"Oh, maybe?" He said, "They bend now." And I said, "Yes, what I did." So I changed from the LCS to a PFC.
So not all knee replacements are the same, obviously.
No.
When you're rehabbing, you can tell the different.
Well, patients are different as well. Like, you sometimes see someone at 3 weeks and they've got 120 flexion.
Yeah.
It's like, shit, how did you get that so quick?
Yeah.
While you were still swallowing. And other people struggle to get 90.
Yeah.
Like, well, what's going on here? Partly patient, partly prosthesis, partly surgical technique, I think.
And I think that's what's happened over time, is the surgical techniques got better. So if you like, with Zimmer, it's the ROSA robot. And so it's worked on gaps so that it works out where the articular surfaces are. So you then range the knee and stress it and see what's happening with the gaps. And again, even with like steel jigs, not the computer, what you're doing is balancing gaps. So you've got a gap between, when you're full extension, you've got a gap between the bones, you can measure with a block of steel. And then you flex the knee 90 degrees, put the block in again, and it should have the same gap. That was how LCS worked. So you're just doing the same measurement, but with the computer. And then once you kind of work through that, you then sort of hit the button and go, okay, this is where we're going to put the bone cuts. And so that then lets you get those sort of gap balancing. But with the problem with like LCS and the steel jigs was steel jigs, you know, you put a rod down the tibia and you put the cutting block on and you got it right every single time. You had no idea where you were, but there was no way of checking it. You just went and cut through the block and that must be right. Whereas with the computer systems, you can look at the screen and go, where are we? Oh, okay, we've got 2 degrees of varus. Oh, that was, you know, the plan was 1 degree of varus. Oh, that's pretty close. And so with the steel jigs, the spread in alignments you got at the end was probably about 10 degrees, 10, 15 degrees. Whereas with the computer systems, it's about 2-3 degrees. So it's a lot more accurate. So you can get their alignment, and now you can tweak it. You can look at them and go, yeah, this knee's always been varus. So I'm going to leave this knee in a little bit of varus, and therefore the ligaments play nicely. So now you're not sort of lax or tight, and they just go through their range of movement. And they wake up and they get going and they go, oh, thanks doc, see you. And it's a matter of how accurately you can get that ligament balance. It's all about ligament balance. Knee replacement is a soft tissue operation. It's just you've got to do it by cutting the bone. So it's about getting the soft tissues right. And that's where, you know, the current techniques let you look at, well, where are they now? Where do they start off? And so that's where that'll give you a target. And you can then look at the alignment of the femur and the tibia. And let's say they've got absolutely neutral alignment, but their tibia's in a fraction of valgus and their femur's in a fraction of valgus and their tibia's in a fraction of varus. They're not like this, they're like this. So you can go, oh, okay, we'll follow that.
It's all for them.
That's where it is for them, yes. And so this is called kinematic alignment. And again, there's a spectrum. There's guys who are full kinematic. They will just follow where that patient's knee goes, and they put up some really crazy looking X-rays and conferences. But the computer system won't let you do that. There's guardrails. They won't let you be more than they won't let you go in more than 5 degrees of varus or valgus. So you'll be within 5 degrees of neutral. Even if you think the patient should be in 10 degrees of varus, the system will not let you go there. So there's like guardrails, like train wheels. You know, it's like, nah, you can't go over there. computer says
Fixed bearing platform or rotating bearing.
I'm using now a fixed bearing platform.
So my intuition about this is if you've got a rotating platform, you've got the normal roll, spin and glide of a joint where it's not just translating and shearing, it's also going to have that rotational element as you come out into extension, etc. So my
It sounds like-
naive understanding of a rotating platform is that's probably going to give you better extension, better flexion, better movement, kinematics. Is that so or not?
Again, there's just different ways of skinning the same cat. So the thing with the rotating platform prosthesis, you've got a tibial base plate. You can stick it anywhere you like. Just stick it there, and the rotating platform goes on, and it just rotates itself out, and away we go. You know, which is pretty easy peasy. If you've got a fixed bearing prosthesis, you've got to get the alignment of the tibial base plate right, so that because that, if you like, locks them into a sort of range of movement. There is a certain amount of waggle, and that's why the tibial base plate is pretty flat, and that allows a bit of translation, and that's where this rotation comes from. And a lot of them, what they'll do is they call a medial pivot. So the medial one is more curved, and it acts as like a fulcrum, like an axle, so that they do this. So they then, if you like, they pivot on the medial side. It's hard to show you, but they do this, not this. You see the difference? So that they rotate about the medial femoral condyle. They don't rotate about the centre of the knee.
So they still have rotation.
So they move the centre of rotation medially.
And the theory is that that's where the centre of the rotation should be. Yeah.
And does that improve flexion and extension as opposed to outcome?
I can't tell you off the top of my head.
Is that a design intent?
I think they're just trying to make it anatomic, aren't they?
Yeah, look, there's lots of different prosthesis designs out there, and originally, when we started doing knee prostheses, the concern was failure rates. So, in other words, what percent of these patients are going to fail each year? And so that came out about 1%. The good ones were about 1% per year fail. Now, if you were having 3% per year fail, after a few, so they run these like lines on a graph. So 1% goes here, 3% goes here. If your prosthesis is doing this, about 5 years, and plunk, you're out. It becomes obvious that your prosthesis is failing at a high rate, and plunk, you're out. So what's happened over time? It's a bit like cars, 40 years ago, the car drove down the road, you could look at it and say, well, whether it was a four-year-old. Now, the car drives down the road, you've got no idea, unless you see the badge, because they all look the same. Because all of they're all trying for the same, they've all got the kind of same design parameters. So they all need to be, aerodynamic and slip through the air. They've all got to have a certain amount of space inside them. So all the designs converge. So they all start to look the same. Same with knee prostheses. They've all sort of converged to about the same. So if you like, the ones that are on the market now kind of all work.
They've survived.
They've survived. And
Nutrition.
So the next dimension is intraoperative navigation and guidance rather than a new shiny metal.
Yes.
well, yeah, so the focus I think has shifted now away from sort of survival, though survival is still critical, and if they don't survive, you're out. But now it's about performance and function. So again, the Joint Replacement Registry has started doing patient PROMs, patient-reported outcome measures. So they give them a questionnaire before and give them a questionnaire after. So that's the sort of frontier now. And so that, again, it comes back to surgical technique. And I think it's more to do with surgical technique than prosthesis design now. So again, when they first came out, which is 70s, 80s or so. It was all about prosthesis design to get something in that knee that's going to survive until the patient dies. We can kind of do that, but it's like, oh, you know, this guy's more comfortable, this guy's got better flexion, you know, so that's where the sort of action is now. And I think that's got a lot to do with that ligament balancing thing.
And survival rate, joint registry results, is too crude and too blunt.
Yes.
Yes.
Just because someone hasn't
Yeah.
had it revised
Doesn't mean
doesn't
it's
mean to
happy.
say it's. So that's
That's
why
right.
the New Zealanders going down the road of proms.
Yeah.
It's the good move, and to hear Australia go that way is good, because there's a lot of people out there with very unhappy
Yes.
knee replacements, and the survivorship is not indicating
That's
whether they're
right.
happy or
And
not.
Case in point there is LCS. LCS, they were lucky to get much more than 90 degrees, but they never fell to bits. Never had to revise one, well, you know what I mean. Never had to revise one. They lasted forever, but they were stiff.
Mm.
So, yeah, so that's an example. So that process, and that's why that's gone out, because that's why I stopped using it, because they didn't get, you know, like I said, they were lucky to get 90 degrees. So that sort of,
And in today's day and age, a patient doesn't going to accept that as an outcome.
yeah, more or less.
Well, they should.
And again, you go back to the like 70s and 80s, and we were digging people out of wheelchairs. And so, you know, you would see people who would have osteoarthritis, and they would have, you know, 60 degrees of valgus, you know, 40 degrees of fixed flexion, and 30 degrees of fixed external rotation. And they're in a wheelchair, and they've got it on both sides. And so, if you can get them something that gets their knee out kind of straight, that they can wait there on, they were really happy about that. That was, you know, they could walk around with 2 crutches, which was way better than being in a wheelchair, you know. So, but that's where, it's so that when joint replacement becomes available in a community, they're the sort of patients who are in front of the queue. And things like, you would see when, say, in India and China, those populations got joint replacements probably 15, 20 years ago. And so you would then like go to a conference and there's some Chinese guy presenting all of those guys, you know, guys with the crazy deformities, because that's, you know, joint replacement came into that country. So those are the people who you start off with. But, you know, now, you know, you've got an MRI to find the bed like, you know, they turn up and want their knee replacement long before they get a deformity. So that's where, again, it used to be, oh, what are the soft tissue releases you're going to do so that you get, you know, this crazy knee, put their foot back under their hip again. Whereas that's gone out now. You never see a knee like
We
that.
do see that a bit in shoulders. I mean,
Yeah.
shoulders were quite significant because
Yes.
it's newer. So
Yes,
I wonder
it
if
is.
you're
Yeah.
describing the same situation in shoulders.
They're newer in terms of their evolution.
Yeah, in terms of the evolution of
They're
the
about
procedure.
10 or
Yeah.
15 years behind knees, which
Yes.
is behind hips.
Yeah, yeah. that's
So,
why you have that.
the thing about a hip is that it's so simple mechanically. It's a ball and a cup.
It's a big deep cut though.
It's a ball and a cup, and so not hard. You can machine a ball, machine a cup, and that's pretty simple. But even so, there's things about getting that right as well, and getting their leg length right, getting the version of the cup right, so that they don't dislocate. And so there's
What they're talking about is when you put the socket in the pelvis, if you put it sort of facing one way or the other, they'll be prone to dislocating it. And so once that's put in, it's set. So if they get recurrent dislocation, the answer is often to revise them rather than you can't just keep putting it back in place. Well, I'll present. But in fact, the answer is the version has got to be corrected.
But and there's kind of gadgets now for that too. I've just started using this thing which I refer to as HipNav, and you put some pins in the pelvis and it's a camera and stuff, and then there's a shiny ball that's on the cup introducer, because there's actually no real way of trialing it. The actual sort of default instrument, there's a little thing that clicks on, so you've got a cup on the end of a metal rod's about that long, and you offer it up the pelvis, you go, there. And then what you've got is like a little rod, it's about that long, and you're supposed to have that horizontal to the floor and lined up with their trunk. But it's like, I'm standing,
Where's
the floor? And so, whereas the hip nav, it just looks at it and puts the numbers on the screen. You go, oh, well, hang on, that's 2 degrees of anti-inversion, not 20. Oh, where should we be? Oh, over here. Oh, right, you know.
So
Getting
it's not
40
way
degrees of
too
inclination. Oh, hang on, we've got, 53.
So it's relative to the pelvis, not the foot. Is that what you mean?
Floor.
Yeah.
The problem
Well-
was we were lining it up with the floor. They were lining it up with the corner of the room. So the patient would have to be in the middle of the room to get the angle right, and they would line the stick up to the corner of the room.
What if the patient's rotated on the table?
Well, that's the problem.
Well, that's a big problem.
The problem with
not straight. It's
static is that you don't know where the pelvis is. So you can do X-rays and see what they do and sit-stand X-rays and that kind of stuff and go, right, this is where we want to put this cup. And then the problem is actually get in the operating theatre. What you do is you put them on their side. That's how mostly you do hip replacement. And you put your hand on the back of their pelvis and go, yeah, that's vertical.
That's it.
And then you have a look at you make sure the table is level, and you assume that they're level on the table. You can have a look at their pelvis and their spine, and if they're level, and then that's right. And then you put them in place. So the first thing you do is you put the pins in the pelvis, and then you calibrate it. So they give you there's a rod about this long. So you put the rod in between the 2 pins, feel it, because you've got a decent rod, and you put it right down on their trunk. So you go, yeah, right, that's where their trunk is. And it says, right, this is the 0 position, this is where I am. So that, but if you like, a rod this long that you can put down onto the patient itself is a lot better than a rod this long. Okay? And by doing it early on, it's before the patient is moved. So, and you haven't like picked up the leg and dislocated the hip or anything, which might move the patient on the table. So you, it's imperfect. Not, compared to the knee, where you can work out where the centre of the hip is quite accurately, and the centre of the ankle reasonably accurately, and it's also a fair way away. So just a little bit of error doesn't contribute much angle. Whereas in the pelvis, they.
Did you have a question about knee replacements as well?
Sorry?
Were we talking? Did you have a question about knee replacements as well? Were we talking about that on the weekend? You had a question?
I've got a general question.
General question.
So on our consent forms when we cut out skin cancers, it says, have you had a joint replacement in the last 2 years? Which I have new patients who have actually had one in the last 2 years, but I presume it's based on the risk of infection and problems and antibiotics as a preventative measure.
Yes.
What's the likelihood?
Okay. So the concern is that somebody will do some sort of something to a patient, and then their total joint replacement will get infected, and then they'll get an angry phone call from the surgeon blaming them for the patient's problem, or perhaps even worse, from the patient's solicitors. Okay, which comes down to how do you get your joint replacement infected? So that the vast and overwhelming majority of infected joint replacements, the bugs got in at the time of the operation. So basically the bugs on your skin at the time of the procedure get in the wound, and because you've got a foreign body there, it sets up an infection. Okay, now that may not turn up for a year or even 2 years, but that's where the bugs got in. The only other way the bugs can get in is what's called hematogenous spread. So they came through the patient's bloodstream. Now, all of us, all the time, have bugs going into our bloodstream, and our immune system can knock them off. Now, you can get infection in a perfectly normal joint. And so when you look at, well, who gets infection in a perfectly normal joint? It's patients who live in poor circumstance, particularly kids. so classically Aboriginal communities, but also, you know, if you kind of sleep in the park, then you're not having a shower on a regular basis, so your skin is chock-a-block full of bugs. Your diet is dreadful, so your immune system is crap. So they've got a lot more bugs in their bloodstream, and so they end up in their joints. And there's nothing about a joint prosthesis that prevents you from getting that. So, you know, when I look back at all the, you know, infected joints that have crossed my path, again, vast majority it got in at the time of their surgery, strongly influenced by the bugs on the patient's skin. I have seen occasional hematogenious spread, and sometimes you'll find the patient will get some sort of systemic sepsis for some reason, and it will land in their joint prosthesis. Okay, that was just bad luck, you know.
I've seen salmonella in a rheumatoid arthritic, so immunosuppressed with a very bad case of salmonella. So it must have had quite a high bacterial load in order to get it infected.
Yeah.
So I think you would have to have a significant problem. And are they saying that the skin surgery is contraindicated if they?
No, it's
No.
just it's just the question is that it's really long
dentists-
teeth cleans for cleaning.
The dentists are even more paranoid.
Yeah,
Okay.
they put them on antibiotics before they clean.
Yes. So,
I understand
anyway.
with RHD on it. Like I can understand that because then you're exposing more antibodies. But for the joint replacement, I would have thought, say they're 1 year down the track, is it much the same in terms of exposure as a normal joint?
Correct.
And that's kind of what I'm getting at, is that it's not something that keeps you awake at night. So that, yeah, you get phone calls from dentists who are, they'll go, I think we might give them some antibiotics. Yeah, okay, give them some antibiotics. See, the risk of giving somebody a slug of antibiotics is not much at all, really. So the cost is not much at all. But the ill effect, infected joint replacement, is pretty dreadful. So it's like, it's pretty cheap, and it might prevent me from something that's really dreadful. The thing which is really hard to factor in is the very small chance of the very dreadful. But it's like, you know, to be honest, I had an implant, not orthopedic, and I went and had a teeth cleaned, and I took some antibiotics.
Just in case. Oh, did you just? There you
So
go.
it's like,
Oh, wow.
okay. I mean, they gave me, I don't know, 4 tablets, which I took a few hours before I went to the dentist. And it's like,
Well, there you go. Yeah, you can do it as a single dose.
Yeah.
I think that's what they gave me.
Rather than
That's
a
what we
course.
used to do.
a single
Yeah,
dose.
well, I mean,
Yeah.
the likelihood of things getting infected anyway, it's going to be cellulose as opposed to something that I can deep. So it's the question of when
It's-
do you give the antibiotics? Do you give it?
And
I'd give it a
if anyone asks about it,
Yeah.
if anybody asks me, I say, yeah, give me antibiotics.
Yeah.
Because it's just too hard. And then it's just too much stress. And it's just like, yeah, have the pills, forget about it, you know. And then, you know, that's a much easier sell
Yeah.
than, you know, trying to explain for half an hour that you don't need it. And then they walk away and think, oh, he doesn't care.
Yes, that's hard.
And it's
I
just
think
like,
that, you know,
yeah, okay.
and you can, and it's the same with that conversation about antibiotic husbandry. You know, it's a long conversation explaining what the value is of preserving antibiotic effectiveness. So that's hard as well. But I would think in your scenario, maybe a one-off hit 2 hours before the procedure, something like that.
So what works? So for things like antibiotic prophylaxis and joint replacements, what works is the antibiotics which are in their bloodstream at the time the operation is done. So for joint replacements, what we do is give them a slug of IV antibiotics when the anaesthetist puts them to sleep. Now sometimes if they're a bit slow off the mark, we'll just have to wait to put the because if you put tourniquet on, of course, doesn't get in. We'll have to wait, you know, so they'll, hang on, sometimes you go to put tourniquet up and the anaesthetist go, hang on, haven't got the bug killers in yet. Oh, okay. And then they'll squirt them in, and then you sort of sit there for a couple of minutes, which is really all the time, and then put the tourniquet on. So that's what works. So yeah, if you were going to you know, for antibiotic prophylaxis, and I don't think it matters whether you give it orally or IV, but you want it in their system at the time of the procedure. So probably orals take 1 hour or so to be absorbed. So, yeah, there you go. You know, when you're coming in for operation on 10 a.m, right, I take these at 9.
But I don't know that there is a huge reduction in infection rate if you keep it going for a day. You know,
No,
so
the-
we frequently prescribe it for 24 hours, but I think it's that shot before you make the incision. I think that's the one.
The
that is.
experimental evidence on infected joint replacements is that it's the one dose, it's the single dose you give them, if you like, at induction, which is the easiest way to do it with joint replacements. That's what makes the difference. That's all. That's all.
Everything else just making it.
And but you kind of give it. We used to give it for 2 days, and the ID guys eventually beat that out of us. And then, but they'll let us get away with 24 hours now. But really, what works is what's in their system at the time you make the incision. So, yeah, if you actually want to use antibiotics for prophylaxis, that's what you need to do. Get it in their system at the time of the procedure.
You thinking about something else?
Oh, no, look, I agree. From that point of view of it
Yeah.
getting infected at that point in time, lots of our patients have told us at times that are licking their wounds,
Yes.
and they're off doing things
But-
that are very sweet, so they probably do need to be continuing on them for a longer period.
Yeah.
If they're at risk, if the
Yeah.
outpatients are in a hospital,
Yeah.
we've got them sitting in a sterile environment potentially for the first 48 hours while the wound's healing. And the wound's not really watertight for 5 days,
The-
when you think about it.
The other thing that, if you like, does worry me a bit is if they've got infection distal to your prosthesis, so that, you know, they've got a, you know, say a knee prosthesis, and they've got, you know, like say the diabetic soggy foot or something, then, because the bugs do travel up the lymphatics, and so, and that you can seed it like that. So if you've got infection in your foot and you've got a knee prosthesis, then you can seed it. But again, usually what will happen is that, oh, I've got an infection in my foot, so it gets treated. So again, if it's getting treated, it's getting treated. So, yeah, but that does worry me a little bit if they've got something sort of, you know, kind of soggy distal to it. So if they've got really active infection in the limb that I want to operate on, I'll cancel it.
But if you're taking out a skin graft, if you're taking out a skin lesion on tight skin over the front of their shin, then people would be very concerned about
So
not
the
having
frequent scenario is having to do a flap on a chin, and then these patients often who have heart failure or other things going on because they're people with those that level of skin cancer up in their skin, and then they frequently have had a hip or a knee done.
Have you ever seen someone come in with an infected implant after?
Not
a-
like that, no.
No.
But then again, you don't see that many, you know what I mean?
No.
It's
It's
not
hard
a
to
frequent
achieve
occurrence,
that.
but in that sort of situation, okay, so they've got a joint prosthesis and, you know, you're doing some procedure further down the leg, then, okay, you might get infection. That's just a risk of the procedure. And it's a smallish risk. And their chances of seeding their joint prosthesis are actually pretty small. But that's where it sort of comes into, you know, following them up. And, you know, you might see them a bit earlier than what you would normally do and have a look at their wound. You know what I mean? You'll kind of keep them on a shorter leash. And if they look like they're going to go bad, you'll jump on them. But, you know, as opposed to just, you know, oh, right, I see you in 2 weeks' time. Oh, hang on, I've had pus dripping out of it for a week. So, and also, you know, it's a matter of often, you know, just telling the patients, phone me up. You know, if you're worried about your wound, phone me up. Which means you end up fielding a few sort of useless questions. But again, I'd rather have a few useless questions than, you know, have patients turn up with delayed presentations. Which I had. I had a lady, rheumatoid lady, whose wound broke down, and she phoned me up one day, it was a weekend, and she said, oh, I went home from hospital, she was on methotrexate, went home from hospital, my wound broke down, and there was clear fluid draining out of it for a week, and today it turned into pus and I feel really sick.
No. So
If I'd have found out that about that a week ago, I'd have put her on antibiotics and kept a really close eye on her. But she was on nothing. And so, you know, I got to know her very well, because if you got infected joint replacement, I'll be seeing you a lot over the next 2 years. So, yeah, but that's the sort of thing. And that, you know, that was a real heart-sink phone call where you just went, oh, shit.
Thank you, Dr. Shepherd. You've hit time. So what we do now is we will turn off our Zoom and we will turn off our Facebook, and then we can ask you the questions.
The questions you really want, right, I see.
Thank you very much. Thank you very much for your time.
Thank you.